Thank you, Chairperson, for kind introduction, and Team Diabetica 2025 and RSSDI for giving me an opportunity to present this talk. My talk is Glitazones, Clinical Relevance in Diabetes Management in 2025 with Pioglitazone is an old unsung warrior. It improves hepatic as well as peripheral insulin sensitivity. It activates PPAR gamma, which significantly improves muscle action, improves glycemic control through the dose-dependent enhancement of beta cell function, acts on adipose tissue, muscle and liver, reduces insulin resistance, and it modulates adipokines and improves glucose uptake. In an era dominated by new age diabetes therapies, pioglitazone remains an unsung warrior, silently delivering powerful multi-organ protection for those who need it most. And we'll see why. There are four major areas of relevancy in 2025. First is its unequivocal effect on atherosclerosis, endothelial function, and CV outcomes. Second is definite impact, positive impact on NAFLD and NASH. Diabetes prevention is very important and its role is very definitive in diabetes prevention. And fourth, it will always be counted on very important aspect, that is efficacy, durability of effect, and cost effectiveness of pioglitazone. So first let's start with its effect on atherosclerosis, endothelial function, and CV outcome. And it has got like very wide effect on CV that improves the endothelial function by increasing nitric oxide availability and reducing the oxidative stress. It reduces inflammatory markers like CRP, TNF-alpha and IL-6, slows progression of atherosclerosis, improves lipid profile, increase HDL, decrease small dense LDL, and potential reduction in cardiovascular and all-cause mortality in selected patients. Now first let's see that how it is improving. In this pioneer study we can see that pioglitazone is independent. Its effect on risk markers is independent from glycemic control. And here we can see that in this prospective study, it improves lipid profile, increase HDL-C, reduce triglyceride, decrease LDL, reduce inflammatory markers, and significantly decrease the CRP, TNF-alpha, and IL-6, the markers of vascular inflammation. In this prospective study, this pioneer study gives evidence of an anti-inflammatory and anti-atherogenic effect of pioglitazone versus glimepiride. This effect is independent from blood glucose control and may be attributed to PPAR gamma activation. So apart from for glycemic control, if you use pioglitazone and glimepiride, then both have HbA1c reduction in a similar fashion, but this additional advantage of pioglitazone on cardiovascular risk marker, we can see that is additional advantage apart from glycemic control. Again, one more Chicago study showed that it reduces the carotid intima media thickness and atherosclerosis, and we can see that comparison with glimepiride and metformin. We can see here that changes from baseline to week 72 in mean and maximum carotid intima media thickness of the common carotid arteries. This study supports the vascular protective role of pioglitazone, especially in early atherosclerosis. Again, the pioglitazone, that was before the prevention of the atherosclerosis with the use of pioglitazone, effect of pioglitazone and development atherosclerosis. But even with established atherosclerosis, we can see here in IRIS study that pioglitazone after ischemic stroke or transient ischemic attack, and here we can see that it was in non-diabetic patient, this IRIS study, and we can see that the development or recurrence of stroke was reduced, or stroke or MI reduced by like 9%, and new onset of diabetes, that is 3.8% lesser. So overall 24% reduction compared to placebo in stroke or MI, recurrence of stroke or MI, and new onset of diabetes compared to placebo were 53% reduction. So we can see here that even in established atherosclerosis disease, pioglitazone works. So it prevents the development or delays the development of atherosclerosis, and it works continuous even with established cardiovascular disease. And this meta-analysis of randomized control trial, very famous, by D. Jung et al., which was published, and pioglitazone and the secondary prevention of cardiovascular disease, we can see here the effect of pioglitazone on cardiovascular endpoints in this meta-analysis, and we can see here that pioglitazone reduced the risk of recurrent MACE by 26%. The relative risk reduction by 26%, we can see here compared to the control group. And reduction in MI, the risk of myocardial infarction decreased by 23%, reduction in stroke reduced by 19%. Though on all-cause mortality there was no significant effect observed, you can see here, but we have to keep in mind that hospitalization for heart failure were increased by 33%. So patient selection with those who are having heart failure or very risk of developing heart failure, we should not use this pioglitazone, but otherwise, if we can see that overall cardiovascular risk reduction is robust with use of pioglitazone. Now we move on to our part 2, that is effect on NAFLD and NASH. This is a renewed interest in this because now NAFLD and NASH has become a very hot topic, and preventable or delayed onset are very important because liver has been now in the center of this diabetes care. We can see that in pathophysiology of NAFLD, insulin resistance that ultimately lead to steatosis, lipotoxicity and hepatic inflammation, and ultimately development of NAFLD. And pioglitazone's role is pioglitazone activates PPAR gamma, enhances insulin sensitivity in liver and adipose tissue, and reduces hepatic de novo lipogenesis and promote free fatty acid oxidation. So it overall we can see that the effect of pioglitazone is mainly on liver, and that is why it prevents or helps in reducing the NAFLD and NASH. And that is why the evidence for supporting this is, one is very famous PREVENCE trial that showed the significant histological improvement in steatosis, lobular inflammation and ballooning. We can see here that steatosis, inflammation and ballooning have improved by pioglitazone. However, in fibrosis stage, there was no significant change was found. Long-term studies also showed that sustained resolution of NASH and fibrosis stabilization with pioglitazone. So fibrosis stabilization occurred, though no improvement, no significant change, but stabilization occurs, and that is why American Association for Study of Liver Disease guidelines endorse the use in biopsy-proven NASH with type 2 diabetes. Our own study I would like to start done by Dr. Vipul Chawda and Dr. Gupta, and that recently published in 2025, which shows that the FIB-4 score reduction from 1.99 to 1.54, and this FIB-4 score decline was observed in both indeterminate as well as high risk group. So overall, all patient benefits with this pioglitazone therapy, particularly those with insulin resistance and NAFLD. So practical benefits of pioglitazone in NAFLD: improves islet ALT and AST levels and reduce the hepatic fat content, enhances the insulin sensitivity in hepatocyte and reduces hepatic inflammation, and benefits are observed within 6 to 12 months of therapy. Now, third point, diabetes prevention, and pioglitazone prevents diabetes with reduces beta cell stress, slows beta cell exhaustion, increases adiponectin, and improves insulin action in liver, muscle, and adipose tissue. And there are numerous trials and studies available to show that the pioglitazone and diabetes prevention. At now trials, 72% reduction in pre-diabetes to diabetes progression. IRIS trial reduced new onset diabetes in insulin resistance patient post-stroke TIA. PEPOD study preserved beta cell function in Hispanic women with prior GDM, and confidence study improved beta cell function in high-risk patients. So, pioglitazone for diabetes prevention particularly relevant in 2025 in Indian population, that is high prevalence of insulin resistance in Indians despite of normal BMI. We have thin fat phenotype in Indian patients. Pre-diabetes epidemic is in urban and semi-urban region is up to 15 to 20%. Dual benefit with early insulin resistance and NAFLD and metabolic syndrome can be achieved with pioglitazone, which is very prevalent in India, and cost-effective, oral, ideal for long-term use in public and primary care setting. It's a cost-effective setting, particularly in our Indian population. So, who benefits the most for the prevention? The pre-diabetes plus NAFLD and metabolic syndrome, history of GDM, postpartum woman with insulin resistance but avoiding lactation period, impaired fasting glucose and high HOMA IR, this is ideal combination, and high CV risk with borderline glucose. So post-TIA, post-MI and insulin resistance. So these are the class of patient where pioglitazone works at multiple level, at liver level, at cardiovascular risk level, atherosclerotic level, as well as the prevention of overt development of diabetes. Now last point, efficacy, durability and cost effectiveness, which is also very important because ultimately patient has to pay for everything, and we can see here that pioglitazone has high durability and HbA1c reduction is robust from 0.8 to 1.2%. Hypoglycemia risk is very low and cost is low. So it ticks all the marks that compared to all other drugs, if we see that durability is high, and we can see the durability, one very Japanese study which showed how much durability of median HbA1c level to return to baseline, and it showed that 5 years of the durable effect of continuous reduction of fasting plasma glucose as well as HbA1c. We can see here this graph showing that 5 years of duration to touching again the baseline. So it is effective and durable for genuinely we can change the outcome of the patient. Now very important to understand that the selection of patient of pioglitazone therapy. So it is based for insulin resistance, mildly obese, NAFLD, early type 2 slides more, early type 2 diabetes and established CVD or stroke. Should be avoided obviously in elderly with CHF, osteoporosis and increased risk of bladder, CA risk, and we have to monitor weight, edema, LFTs, and bone health. That is why it is recommended in almost all the guidelines, global guidelines. It is been mentioned in as a second line, third line drug of choice. Even ADA, ESD valid option to consider in insulin resistance, and NFLD insulin guideline recommendation by ESI RSSDI clinical practice recommendation 2020, and we can see our own RSSDI ESI therapeutic wheel. If we can see that in green zone, in the yellow zone, all pioglitazones, all zones such pioglitazone, and in the zone such as green, yellow to red suggests the intensity of the disease, and even with the red intensity you can see that apart from A, B, C, D, the E, F, G, H, all four quadrant mention the pioglitazone we can use. So it has the wide applicability, cost effective, durable, and that is why it is very relevant in 2025. If we can use it properly, our patients are benefited the most. To summarize, re-emergence with evidence, lots of evidence are there to use in post-stroke or prevention of other all spectrum of cardiovascular patients. Multidimensional benefits. It works on the insulin resistance, liver, cardiovascular risk, and beta cell preservation. Proven in prevention, effective in delaying onset of diabetes, cost effective and easily accessible, and sustainable option for durable effect, oral administration, and minimal risk of hypoglycemia. Thank you.